Sites. Till now, we've had 4 episodes, two on shoulder, one was instability, one was proximal humeral fractures. We've had two on the knee, one was on the chondral defects, and one was on the osteotomy. So this is the fifth episode, and I'm very thankful to all our faculty who have joined us and all the viewers who are viewing us. This is going to be a webinar on PCL, and I think PCL is something which still bothers some of us, especially me, I can say so. ACL is something, you wake me up in the middle of the night, I can do it. But the PCL is something, if I get a case, I have to think, I have to plan, single bundle, double bundle, what graft options, do I need to take a graft from the opposite side? Do I at least get a thickness of 10 if it's single bundle, or at least 7 or 8 if it's double bundle? So all these questions cross my mind. Therefore, we thought this would be a very useful webinar to take us through the basics of PCL reconstruction. And for this, we have a very, very eminent panel. We have Dr. Deepak Chaudhary from Delhi. We have Dr. Chinmay Gupte from UK. We have Dr. Milind Pimprikar, who does a lot of PCL work, and Dr. Ranjit Panigrahi, who has a rich experience in PCL, and Sachin Kale, who will be sharing his experiences with us. So in all, I think for the next 1 hour or 1 hour, 10 minutes, we are going to have a lot of useful information on PCL reconstruction. So without any further ado, let us start with the webinar. And we have 5 presentations. The first is by Dr. Ranjit on anatomy and the PCL graft options. We have the second one on single bundle by Dr. Milind Pimprikar, double bundle by Deepak Chaudhary sir. Then we have the PCL outcomes and what is different in elite athletes by none other than Chinmay Gupte, and then Sachin Kale and myself will run the case discussion. So over to Dr. Ranjit for his presentation on anatomy of PCL and what are the graft options. It's all yours, Ranjit. Thanks for joining.
Yeah, thank you, sir, and thanks for the opportunity, Dr. Parag sir, and the OrthoTV and the entire esteemed panel and all the viewers. So I'll be speaking on the PCL anatomy and graft options. Just now sharing. My presentation is visible to all.
Yes, very much.
Yes.
So now, is it in slideshow mode?
Yes, it is.
Yeah.
Yes.
So the PCL anatomy and graft options. So what is the PCL anatomy? Because as far as anatomy is concerned, we are very much worried about the PCL because PCL has diversity. PCL reconstruction has got a diversity of this opinion how to go for it, and so PCL anatomy is very important. So the posterior cruciate ligament is the strongest and largest ligament in the human knee, and the primary posterior stabilizer of the knee. So it is an intracapsular and extrasynovial ligament, and with a broad crescent-shaped ligament of 32 to 38 millimeter length, and the diameter is 1.5 times more than the ACL footprint. And what has been suggested by Girgis et al. In the clinical orthopedic and related research. So the PCL is a fan-shaped structure which is extending from the medial femoral condyle up to the tibia, and it's inserted just 1 to 1.5 centimeter distal to the tibial plateau. So if you come to the femoral part, it's attached to the medial intercondylar notch in the form of 2 bundles. One is anterolateral bundle and second is posteromedial bundle. They are approximately 2 times the attachment size on the tibial side, and it ranges from 112 millimeter to 118 millimeter. The anatomic centers of ALB and PMB femoral attachments are average of 12.1 millimeter apart. So as per the Laprade, the medial femoral condyle is divided into 3 points: trochlear point, medial arch point, and posterior point. So the PCL femoral attachment is dispersed over this entire area. From the trochlear point to the medial arch point is the anterolateral bundle, and from the medial arch point to the posterior point is the posteromedial bundle. So if you come to the anterolateral bundle femoral footprint, it is along the roof of the intercondylar notch. And mostly in case of single bundle reconstruction, we are much worried about this anterolateral bundle, and most of us reconstruct this anterolateral bundle. And the center of this anterolateral bundle is 7.4 millimeter from the trochlear point, 11 millimeter from the medial arch point, and 7.9 millimeter from the nearest point on the distal articular cartilage. So if you come to the posterior medial bundle femoral footprint, it is little posterior and inferior, and average area ranges from 60 to 90 millimeter square, and center is located 11.1 millimeter from the medial arch point, 10.8 millimeter from the posterior point of the articular cartilage, and 8.6 millimeter posterior to the distal articular cartilage margin. So if you come to the PCL tibial attachment, Laprade has described the bony landmark by dividing the attachment into two parts by a bundle ridge, and the anterolateral bundle insertion lies posterior to the bundle ridge. Anteromedial bundle insertion lies anterior to the bundle ridge. Plateau, and so, when we are discussing about the tibial attachment of the PCL, we should be PCL, but
We are not able to hear you well. Ranjit?
and
Ranjit? I think we lost his screen also, right?
Yes, sir. Again, it is come back.
It has come back.
So I think let us start with Milind sir's talk. I think his connection is weak. Ranjit, I think you just start your presentation again. We missed you, and keep your video off. I think your connection is low. Can you share your screen now? Yeah. We can't yet see your screen. Okay, yeah. Now you can just keep the video off and continue. We can see your slide. Perfect.
okay.
Please continue. And speak a little loudly.
Okay. So when we are discussing with the posterior cruciate ligament, so we should be aware of this meniscofemoral ligaments. One is anterior meniscofemoral ligament of Humphrey, and the second one is a posterior meniscofemoral ligament of the Risberg. So anterior meniscofemoral ligament is present in 74 to 75% of the cases of knee, and in posterior meniscofemoral ligament is present in 59 to 80% of the knee. So a posterior meniscofemoral ligament femoral attachment is found proximal to the posterior medial bundle and the medial intercondylar ridge. It's not moving. Okay. So the strength of this PCL is 2,500 to 3,000 Newton, and it minimizes the posterior tibial displacement in 95% of the cases. If we come to the blood supply of the PCL, it's mainly through the middle genicular artery. And if you can see the bundles again, the anterolateral bundle is more horizontal in extension and vertical in flexion, whereas the posterior medial fibers are more vertical in extension and horizontal in flexion. So, when coming to the functions of these bundles, anterolateral bundle fibers are horizontal in full extension and becomes more vertically oriented in higher degree of flexion. In contrast, posteromedial fibers are more vertical in extension and horizontal in flexion. So, the ALB acts as the main restraint to the posterolateral translation at higher degree of knee flexion, say around 70 and 105 degree, and posteromedial acts as the main restraint to the posterolateral translation close to the extension. So the main biological biomechanical function of the posterior cruciate ligament is to restrain against the posterior tibial translation at all flexion angles. The ALB and PMB were originally thought to exhibit the reciprocal independent function, which is anterolateral bundle is predominant in deep flexion and posteromedial bundle is predominant in extension. But the recent literature and the biomechanical studies, they exhibit the synergetic and co-dominant behavior. Now it is very important because the entire range through the entire range of movement of the knee, the PCL is restraining the posterior tibial translation by this co-dominant behavior. That is, both the ALB and PMB provide resistance to posterior tibial translation throughout all the flexion angles, and the PCL as a whole has been reported to contribute up to 95% of the posterior knee stability between the 30 and 90 degree of the knee flexion. So coming to the graft options. So what is the ideal graft for PCL reconstruction? The ideal graft properties are those that stimulate the anatomic properties of the native ligament of the PCL, including the size and geometric shape. So what are the graft options we have for PCL reconstruction? So one is autograft and the another one is allograft. When we are coming to the autograft, then most important is the bone patellar tendon bone graft, hamstring graft, quadriceps tendon graft, and offlet peroneus graft. The second one is allograft tissues, mostly Achilles tendon allograft. The others are tibialis anterior, posterior, peroneus longus tendon, also used as allograft. And recently, synthetic grafts also are being used for PCL reconstruction. But as such, there is no ideal graft for PCL, as none of them can closely resemble its complex anatomy, which can be replicated during the reconstruction. So, when we discuss about the bone patellar tendon graft, it is considered gold standard for all cruciate reconstruction, mostly for ACL and for the PCL also. So we take the middle third of the tendon 10 to 11 millimeter. We give the medial vertical incision, sometimes two incisions, sometimes one incision for the cosmesis, and we take the bone plug appropriately. And on the tibial side, when we are using it for the PCL reconstruction, most of the times we can use it as onlay graft. So coming to the BPTB graft, what are the advantages? It is the very easy to harvest, consistent size and shape, strong to bone fission, and good healing properties. But advantages of the bigger incision scar and loss of sensation, as we all know, lateral to the scar. So though it's a gold standard, there are having it is having certain disadvantages. So coming to the hamstring graft, which was most commonly used graft for ACL and PCL. So mostly for PCL, we use quadruple semi-T only if you are planning for a all inside construct, and a doubled STG graft, we take the semi-T and gracilis to have the adequate diameter of the graft. So we use the four strands of the hamstring for the PCL, and which is 250% strength of native ACL. So advantages of this hamstring graft are stronger graft, smaller incision, cosmesis, can be used in skeletally immature personalities, and disadvantages being the soft tissue to bone healing, tunnel widening, loss of hamstring strength approximately 10%. Coming to the most important graft, which is the quadriceps tendon graft, which is more frequently used for the PCL reconstruction of late. It's a reliable and robust area of 6, can be used bone block, less risk of infection, compared with the hamstring, less risk of injury to the infrasapinous branch of the infrasapinous branch, and lower donor side morbidity 0 to 15% versus 18 to 51% in BPTB, less anterior knee pain 4.6% versus 26.7% in BPTB, and it can be harvested minimally invasively as well. So without giving a big incision, we can just give a very small incision which is cosmetically appealing, and then can harvest the quadriceps tendon graft, which is very useful in PCL reconstruction, and we are using it regularly of late. But the disadvantages also there with the quadriceps tendon, with prolonged quadriceps weakness with full thickness grafts, donor side pain, fluid extravasation during the arthroscopy. So we can see through the arthroscopy the course of the tendon, and then mark the course of the tendon and take the Quad Pro harvester. There are different kind of harvester with the different companies. You can use either of the harvester, and then according to your need, mostly for PCL we take full thickness, or according to your need at least 9 to 10 millimeter of the quadriceps graft you can take, and just you can pass your harvester up to the required length you want, and then you can just withdraw it and then pass your suture through the slit. And once the suture is out through the slit, again you pass your Quad Pro harvester up to the required length, and then with the cutting slit you just press it to cut at a required length. So there are certain complications as well in quadriceps harvest: post-operative hematoma, patellar fracture with bone block harvest, and rectus femoris retractions. So coming to the peroneus longus graft, which is also usually mostly taken nowadays for PCL reconstruction, I take this peroneus graft with double incision technique. I give incision just above the ankle and at the base of the first metatarsal to get a very long tendon, so that it can be tripled or even quadrupled to get the adequate diameter and adequate length for PCL reconstruction. The advantages being the comparable biomechanical strength, larger graft diameter, reduce knee donor side morbidity like hamstring weakness, no anterior knee pain or kneeling pain, no risk of saphenous nerve injury. But it has got some disadvantages like hypoesthesia around the lateral side of the foot, mild weakness in eversion, transient peroneal nerve injury, compartment syndrome also a very rare complication. Now coming to the last one, allograft. It is not accessible to all areas of India, but it's accessible in many places. So it has got a decreased surgical time, predictable graft size, decreased morbidity, and easier recovery. But disadvantages again, cost and availability issue, risk of disease transmission, delayed incorporation, high failure rate, a lower return to sport as compared to autograft. So indication of these allografts should be patients aged more than 40 years. Multi-ligament knee injuries, you should use allograft. If the patient prefers not to give autograft, you can go for allograft. Previous harvest from other donor site grafts not available, you can go for allograft. And inadequate autograft tissue also, you can go for allograft. So after discussing which graft is better, we think all grafts give excellent result in terms of functional outcome clinically and instrumented examination also. But you should choose the graft depending on your experience and training and comfort level. But the choice of graft should be individualized. You should consider your choice of graft according to the patient's age, activity level, sports and level of competition, risk factors for failure, available grafts with history of previous surgery, and patient preference. Thank you very much.
Thank you very much, Dr. Ranjit. A great talk. You gave a good start to this webinar. You can stop sharing your screen and let us have a few questions. If anybody in the panel has any questions, they can ask. But let me ask all Elite. He has a isolated PL injury, a 35-year who does play sports and who wants to get back to his sports. What would be your graft options, or how do you choose which graft to use in an isolated PCL injury?
Sure. So I think in terms of elite sports, you've got to think about the sport they're playing and also the position they're playing. I'll give you a very simple example. Rugby you have many different positions in rugby. So the flanker and the winger are sprint positions. You don't want to be taking the hamstring tendon for the flanker or the winger. So I would take either quadriceps tendon, or if they're slightly older, I would actually take an allograft, which I'll come on to in my talk. If you are looking at a prop who is basically pushing very hard against their opposition player in a scrum, then you don't want to be giving them anterior knee pain because they are basically kneeling or in deep flexion loading all the time. So in that situation, you might take a quadruple hamstring or possibly even a quads. They still have decent power, but I worry about the extensor mechanism. So I think it's very sport specific, and not only that, it's person specific. Again, you've got to look at hypermobility, all those things as well. Patella tendon is a very reasonable graft in the hypermobile.
So, Dr. Deepak, in a patient who comes to you who is not an elite athlete, who is just an office goer, plays sports over the weekend just for recreation, what would be your graft option? Deepak sir.
Uh, yeah, Parag, our main experience with PCL has been our go-to graft is the hamstring tendons. So whether we are doing a single bundle or a double bundle, I prefer hamstrings. And if the diameter is not sufficient for when we are doing a double bundle, we take the peroneus as well. So
Would you
mainly
go
it
for
is
the hamstring
hamstring.
on the opposite side instead of the
No,
peroneus?
no, no.
You will not touch the opposite knee.
No, no, the patients are not that happy touching their opposite knee. So
Dr. Milind,
our
your
results
graft
are quite
options.
good with hamstrings and if required
Okay.
peroneus.
Yes, Dr. Milind, your graft options in a
So,
non-elite athlete.
yeah, so very aptly put by Sir, in a non-athletic population, which may not be even a weekend warrior, which is the most common subset of patients in our country, I still rely on hamstring graft as my first graft choice, barring all those parameters which Dr. Gupte talked about, like hyperlax patients. Those are different individuals we're not speaking about. But peroneus is also a good choice. And of late, I've used a lot of peroni for isolated PCLs, and they do well. But basically, my graft choice would be a soft tissue graft and not bone patella tendon bone, as far as non-elite athlete or a sports person is concerned.
Okay, so Ranjit, one quick question to you, and then Sachin, you can ask a question. What is your choice between a peroneus longus graft or a quadriceps graft? If the patient consents for both, let's say, so what do you prefer, quadriceps or a peroneus longus?
As far as this
I think put your video off, Ranjit. We are losing you. Yeah.
concern using foot by the mechanism. Peron has demonstrated that studies have come out that the harvest the peron, but certain may do uh, which with
I think
harvest.
Ranjit, we are losing you. Your voice is not clear. So, Sachin, any quick questions?
Yeah, question to Milind sir. Any preference or why like Peruna is coming now? Like, is it due to the diameter and the length, or like why do we prefer more? Not more, but little bit preference to Peruna because in latest now.
You're mute, sir. Unmute yourself.
Yeah. So, soft same way. Carpe was and an aspiration is the both patella a bone and a soft are different. So if I have tissue graft, I'm quality of collagen cross section of the where die easily harvest donor side more I'm they do not act any activity operate best whether you suture but
Okay.
length, you get a good diameter, and that's why I feel that peroneus would probably be the choice.
Okay, I
Deepak sir,
think
any?
let's go on to
Okay.
the next talk,
Yeah.
and we can have more questions after Dr. Milind's talk. Dr. Milind, now let's start with your talk, and you're going to take us to the technique of PCL and single. So, your presentation and start with the second talk. So, about 8-9 minutes presentation, and then we'll have questions again.
Perfect. So are you able to see the screen now?
Yeah, and we can hear you well now.
Right. So this is a technical talk on single bundle PCL reconstruction. Anatomy we have already seen, biomechanics we have already spoken about. So we know that functionally PCL is a primary restraint to the posterior tibial translation at all angles of flexion. It is primary restraint to internal rotation beyond 90 degrees of knee flexion, and it functions as a supplementary restraint to external rotation beyond 90 degrees. Historically, as Ranjit very rightly pointed out, it was thought that ALB and PMB, they have reciprocal functions, with ALB function in deflection and PMB in extension. But recent biomechanical studies, they suggest that they have a codominant role, and ALB functions at 70 to 105 degrees of flexion, whereas PMB functions at 0 to 15 degrees, which means that both the bundles are active throughout the range of motion, and that probably forms the basis of why do we do a double bundle PCL reconstruction, and biomechanically sounds to be a better option as compared to single bundle. We know that there is something called as champagne glass drop-off, which is the anatomical side where we put our tibial tunnel. And on the femoral side, we know that the posteromedial bundle and the anterolateral bundle, which probably kisses the articular cartilage, and it is placed O-clockwise at 11 o'clock, which starts from the trochlear point to the medial arch point, according to the Leprat's anatomy, which is described as arthroscopic anatomy, and very aptly put here. So that is the length where the whole anterolateral bundle would extend, and you have the meniscofemoral ligaments probably flanking them from anterior to the posterior. On the tibial side, we know that it's a trapezoid area. You have white shiny fibers here which attach the root of the meniscus, and you should be careful about this when you're drilling a tibial tunnel there or dissecting posteriorly. And that's probably the region where you're going to put your tibial tunnel when you do a single bundle ACL. That's a very classical clinical sign called as reverse Lachman's, which is on the table under anesthesia, and one could see that reverse Lachman's is strongly positive in this patient. That's an arthroscopic sign which absolutely tells you about the PCL deficiency, and it's called a sloppy ACL sign. So when you do that, the ACL slops on itself, and that indicates that the patient has got a PCL, a grade 3 PCL injury, which probably is a grade 3 injury. When you come to the technique of a single bundle, there are various techniques. For example, few people would take two posteromedial portals, one superior, one inferior. Few would take a posteromedial portal and a posterolateral portal along with the standard anterolateral and anteromedial portals. For me, I do it the PM portal and PL portal wise, and my standard anterior portals are a little higher as compared to what I do it in ACLs to have a over the top view and to identify the anatomy in a better way. So the essential steps are creating certain windows. Now this patient had a ACL as well as a PCL injury. Now my shaver is between the ACL and the PCL, where ACL is not existent here, and that is why it is easier to go to the septum and shave the septum to enter the posteromedial compartment. When the ACL is intact, what I do is I switch the portals and I see from the anteromedial portal and get my shaver in from the contralateral portal, so that I get a direct trajectory to shave the septum and enter the posteromedial compartment. I have entered here the posteromedial compartment from between the medial femoral condyle and the PCL, and I have taken a posteromedial portal by inserting a needle onto the synovial fold and then 11 number creating a port. The port is dilated with a hemostat, and you pass a switching stick or a Wissinger rod which kisses the posterior aspect of the lateral femoral condyle and exits out of the lateral side, sparing or far away from the common peroneal nerve. Now I am seeing from the posterolateral port, which is a normal eyesight and hand-to-eye coordination for an arthroscopy surgeon, because we are used to seeing the knee from the lateral side. and my shaver has come in from the posterior medial port, where I'm trying to shave the septum completely off to identify the anatomy of the PCL and its insertion onto the tibia. Here one can be safely shaving by facing the shaver blade towards the PCL rather than towards the capsule. But once you're seeing it from both the portals, you get a capacious posterior space and probably would have lesser chance of damaging anything onto the posterior side. So electrocautery can be used as the medial meniscus. Those are white shiny fibers. You identify the anatomy. That's the region where the ramp lesion occurs, and we treat ramp lesions there. You go right till the bottom where you see a fat pad, or you can even see the popliteus muscle fibers, where you identify that you have gone inferior enough to find the PCL attachment onto the tibial side. You switch the arthroscope here again anteriorly and pass your PCL jig for the tibial prep. And this tibial jig goes onto the posterior side, onto the tibial footprint, where you switch the scope to the lateral side and identify about 15 millimeters below the tibial plateau where the attachment of the anterolateral bundle lies. You can see a Wissenger rod coming in from the posterior medial port, which is protecting the posterior capsule in addition to the jig. And the bit pin is seen entering under the vision, where you can see it is entering the footprint or the anatomical footprint on the tibial side. Once that is done, a definitive graft size drill is made onto the bit pin from the medial tibial surface, and that's the bit pin coming in. You have a protection there, and you have drilled the hole. Once you have done that, there is a suture shuttle which comes in and is taken out from the posterior medial portal and is parked into the posterior medial portal. Once you have parked this, you know that you can shuttle the graft now, and this is one way how one can shuttle the graft from tibia to the femur. At this point in time, again, the portals are shifted and the scope is put into the anterior port to see for the femoral anatomy and femoral footprint of the anterolateral bundle. So that's your suture shuttle. That's the switching stick, which you can see from the posterior medial port. It is parked there. Now this is retrieved from the anterior port so that you create only one suture to pull the graft when you're pulling it from the tibia to the femur. While doing double bundle, we usually pull the graft from the port, that is the anterior port, and that usually avoids the killer bend. Now that's the anatomy onto the femoral side, and that's the part where I would like to put my femoral tunnel, which is kissing the articular cartilage, and it is exactly at the medial arch point. It is done in the similar way as you do it for the ACL, but we do it at 90 degrees of knee flexion here. I operate in a TKR position. So you push in a bead pin, which is over drilled with a 4.5 millimeters endo button drill bit. The tunnel length is measured, and a definitive drill is used to create a socket where one can put the femoral PCL. I use a suspensory fixation onto the femoral side and a bio screw or a metal screw onto the tibial side. Now that's the shuttle which you can see, and that's a single suture. So here one can use a Wissenger rod from the posterior medial port to avoid the killer turn and aid the graft to slide into the femur easily. And the other way to do it, one can use a probe from the anterior port, which you can see here, and you can lever these sutures out with the endo button. So this gives you the same principle of levering the graft inside the joint. And this graft has to come between the ACL and the PCL when you're doing isolated PCL. Here, I have to do ACL later on. So I'm not worried about from where the graft is actually coming in. And those are the sutures which have come in. That's the endo button. I have marked the graft. This is a 15 millimeters endo button. So I know where is my mark and where my graft is going to flip. So it comes as a tissue preserving surgery. You can see the PCL fibers intact onto the femoral side. That's my mark where my endo button gets flipped, and then I fix it with a bio screw anteriorly. That's the ACL being done in the same sitting later on, and one can see the exact obtuse angle between the ACL and PCL when both are reconstructed, having the anterolateral bundle and soft tissue preserving surgery on both the ligaments. The patient also had a bucket-handed tear of the medial meniscus, which was then which was initially then sutured, and that's a stable meniscus rim with a stable root there, completing the procedure of a single bundle ACL reconstruction. So to conclude, although double bundle PCL is biomechanically superior option, single bundle also yields the same results with no significant difference as far as long-term outcomes are concerned. PM and PL portal allows a better visualization of the anatomy and safe dissection. Graft choice is basically a surgeon's preference. What one could use a soft tissue graft or a bony graft. I thank you for your attention.
Thank you very much. Excellent talk, Dr. Milind. I think let's go through the next talk, which is going to be on double bundle, and then we'll take a break for questions before Dr. Chinmay goes on with his talk. So, Dr. Deepak, can you share your screen? And Dr. Deepak is going to speak to us on double bundle. He's gained a lot of popularity with his double bundle ACLs. Now he does a lot of double bundle PCLs. So let us hear from Dr. Deepak that his double bundle is the way to go in PCL reconstruction. Unmute.
Yeah.
Yes.
So thank you very much for the kind invite. So we have come a long way over the past 2 decades from our postgraduate days where every PCL or for that matter multi-ligament injured knee used to be casted for six weeks and resulting in a still and functionally useless type of. Much of that has been because of the better understanding of the anatomy as well as the biomechanics. And for that, on anatomy and biomechanics. So PCL reconstruct the following points we have to consider: the diagnosis, radiological, and then finally the actions and how to improve outcomes. So this analysis by the previous two speakers, and just know that the anterolateral bundle extends from the trochlear point to the medial arch point, and the PM bundle is below that and about 6 to 7 millimeter from the articular cartilage. And the tibial insertion has also been very well defined on the bundle ridge, which is present 5 to 6 millimeter of the champagne glass drop off, and the arthroscopic point is between the shiny fibers of the medial meniscus and the champagne glass at the bundle ridge. I'll show you in my video presentation. So biomechanics has also been discussed in detail, and we all know that now the latest studies show that both the bundles, they have got co-dominant and they are synergistic in action, and they are tight in they act in both all degrees of flexion. That has been very well covered by the previous speakers. So the mechanisms of injury of PCL either could be high impact forces during sports, or it could be road traffic accidents. And when we are dealing with PCL, one has to be very careful to see whether there are any other ligaments involved, especially the PLC, which is often missed. And resulting posterior drawer test is the commonest test that we use, and then we have the active quadriceps test. And these tests can be further validated by the stress X-rays, which are considered, which we routinely do in our practice. And if the displacement of the tibia is less than 8 millimeter, it's a partial tear. If it is between 8 to 11, it's a complete. And if it is more than 12, always suspect a associated injury, usually a PLC or a posteromedial corner injury or a root tear. So all these facts you must consider in your while you are preparing the patient for assessing the patient for a PCL. Then the diagnosis is confirmed on a PCL, but more importantly, on MRI, we look for any other associated injuries which one could miss, and especially root tears are also quite common, and the PLC injuries are also quite common. So these are the associated injuries one must see, and the stress X-rays, they show whether there is more than on the lateral side, the amount of opening, which Lapredet has given some measurements which we are following in our clinical practice. So when you considering a patient, you have to see consider the age of the patient, the activity level, the degree of posterior tibial translation, and always look for the knee as a whole and look for the associated meniscal injuries, ligament and the cartilage injuries. And in a chronic situation, again, limb alignment is very important. Patient might require an osteotomy, especially if there is a PLC injury, old PLC injury, the limb could be in varus. So there are some situations where we could manage it conservatively, which is an isolated PCL grade 2 injury or an sedentary or an obese patient. But usually surgery is required when there is a grade 3 PCL injury in a multi-ligamentous situation, when there are associated meniscus or cartilage injuries, or there is a limb malalignment. So coming to the our topic of interest, single bundle versus double bundle. So though clinical outcomes long term, they show that the results of both are similar, but then there are certain objective measurements and objective testing which show that there is more sagging and more persistent laxity in the single bundle as compared to the intact state or as compared to the double bundle PCL. So with the double bundle tensioning, the posterior sag is much less, and in all the angles of flexion, it has got a good stability. So the double bundle PCR more close, we know the biomechanics and the anatomy now, and the double bundle PCL more closely approximates the native kinematics, and there is greater resistance to posterior translation. So we all know that they have now co-dominant action. This has already been covered. And then again, as I said, posterior tibial load, when it is applied in cadaveric studies, the posterior sag in cases of single bundle could be close to 5 to 6 millimeter, whereas with double bundle it is about 1 to 2 millimeters. So this is a case which I'll be showing the surgical video. So this patient had a medial meniscus root tear also. And this patient, as you can see, there's a sloppy ACL. If you give an anterior drawer test, the ACL becomes taut. This is not an ACL, but cartilage. There one can use now we are using the inside out drilling using the reamer as a guide. So this is the outside in an old video where we clean the mouth of the tunnel, and then once that we have made that tunnel, the second tunnel for the posteromedial bundle. This is the second tunnel for the posteromedial bundle. This is 5 to 6 millimeter from the cartilage. And as you can see, there is about 2 millimeter wall between the two bundles. You can see there is about 2 millimeter wall between the two bundles, which we maintain. Now we come to the back of the tibia, and the important landmarks. These are the shiny fibers. One must avoid them. One can frequently result in a root, and sometimes we use a posterior, and sometimes we use a posteromedial, and then we pass two loops to the outside in, to the two down into the tibial tunnel. And now gradually we pass the PM bundle in zero. So so root tears, the posterolateral tear, which corners a bio screw to fix this in the tunnel, and also use a supplement bundles there. They are quite anatomical. So this is the post of CT scan, which we often do just to validate our tunnels. And as you can see, the tunnels are in correct position. And there is review of literature, the comparison of single and double bundle, though long-term results might be similar, but the double bundle definitely provides better knee stability. And another study also goes that the results were superior with a double bundle piece. Gymnast, and at 10 months you can see. So the take-home message is patient selection again is very critical. One has to see for all the injuries, examine the need again, a lot on the experience of the treating surgeon, especially if there is a multi-experienced team, which we are very fortunate to have. And I think double bundle return is the way to go forward. Thank you very much for your kind attention, please.
For discussion,
Yes,
Sachin,
one
you have any questions or any of the panelists has, we can take them now.
Deepak sir, I want to ask you,
Yes,
like,
yes.
is there any
Try to make it a habit of testing the our results. So one feels satisfied when the stress X-ray gives you good result.
So Ranjit, I
thank you,
have a
sir.
question for you. In your practice, are you for a IT professional or office goer? Do you prefer a single bundle or do you prefer a double bundle technique for your PCL? And I think it's almost universally accepted that the tibia single bundle is good enough. The debate is always in the femur. So what is your take? Do you prefer a single bundle or double bundle isolated PCL?
Sir, isolated PCL in 90% cases I use single bundle only. As such, also in 90% cases I use single bundle. I always preserve the remnant of the PCL, and along with that I do the single bundle PCL reconstruction to get a very good result.
Okay.
Always.
Milind
Chinmay,
sir,
what's your take? I know you're going
yeah.
to say something in your talk as well, but a quick comment on IT professional, occasional sports player. Is your go-to single or double bundle?
Mainly single bundle, I would say, because they're
Single
not
bundle.
that demanding, and it's slightly simpler. I think the suture management is really important with double bundle, so my preference is single bundle in that sort of situation.
Yes. Sachin, you were asking a question.
Yeah, asking to Milind sir regarding the posterolateral portal, because that is little, what are the precautions, any tips and tricks for the posterolateral portal?
Yeah, so we are all very comfortable with doing the anteromedial, anterolateral, but for a PCL, we have to do a posterolateral, posteromedial portal. I think that's very, very important. So, Milind, any quick tips on, how to get that posteromedial
So,
portal in the first go?
Posterolateral. Yeah.
so the
Posterolateral,
chronology
yes.
is very important. My video is stopped by the, I think, unable to start video. You can't start because host has stopped it. So is it okay?
I don't know.
Speak without video.
No, of course, no. You
No
should be. I
problem,
don't
sir.
know why.
Okay.
Uh,
So,
can somebody start his video? One sec, sir. I'll just check.
Maharishi, please start his sir's video.
Yes, sir.
You can
yeah, now
start your
that's fine.
video. Just try. Perfect.
Yes.
Perfect. So, I follow a chronology or steps, each step every time and the same one. So, two windows which are very important. That is the window of the septum that enters the medial compartment. And then you have second window between the MFC and the PCL remnant. You take the posterior medial portal, which is slightly higher, onto the synovial fold. It consistently should be there. So it gives you a over-the-top position to pass your switching stick. Once you do that, you keep your scope near the septum and see that switching stick is entering the hole which you have created into the septum. Now, this switching stick then passes ahead under the vision, which kisses the lateral condyle of the femur. And once you kiss the lateral condyle of the femur, it usually comes out much above the fibular head so that you don't have much risk there. There is no important structure there. So you just shove the stick in, let it come subcutaneously. You can feel and see the Wissinger rod coming out. And with the 11 number blade, you just nick it open. Once you nick that open, you take your sheath and thread it over the Wissinger rod and gradually withdraw the Wissinger rod, which takes you through the septum to the posterior medial compartment, and life becomes very easy after that. I think I've made
Perfect.
it clear how I do it.
No, it's very clear. I think let's go on with
Perfect,
the
sir.
last talk, and then we are
Yeah, my
nearing 8
question
o'clock.
to
So
Deepak sir.
Yeah.
yeah, one last question, and then we'll go to the talk. Yeah, please
Yes,
go ahead,
Yeah,
very
Ranjit.
good.
Deepak sir, when you are doing a double bundle PCL along
Yeah,
with your MCL injuries, suppose your
yeah.
MCL POL both gone, you want to create POL and MCL tunnel for the MCL and POL injury. Along with that, you are going for double bundle. How you are managing all your tunnels on the medial
Actually,
side
for
of it?
that you should be very thorough with your anatomy of the medial side, and for that the Lapreday has made very nice recommendations. And important thing is that you follow first of all, is the adductor tubercle. And once you know where the adductor tubercle is, then 12 millimeters below and 8 millimeters in front, there is your medial epicondyle. So just you make your entry point for the superficial MCL. And then, well, again, the important thing is that you identified the 6 millimeters behind the adductor tubercle. And again, your tunnel trajectories and anatomy pretty well, you can avoid dual tunnel. But again, having said that, when multi-ligamentous situation, and apart from PCL and PLC also, because in a we often in such cases do a single bundle PCL only to save time also, and to avoid this convergence also. But we have had experience of doing PCL plus MCL with both the bundles of the PCL as well as the superficial MCL as well as the POL.
So with
That's
the
Great. So
larger
Milind, quick
knees,
comment and then we'll
knees, you
go.
can
Pardon?
with the
I couldn't
larger
stop.
knees you can get away with doing 4 tunnels, but smaller knees like our Indian females, so your advice better to go
So
for
we
single
do this only in
piece.
good athletic population only. Yeah.
Okay, sir.
Yeah, Milind,
So
you
it's
have
a
quick comment?
Morche. Yeah, no, not quick comment. The viewers are directed to a paper by Laprade Group by Morche, who has given all the trajectories and the angles how to avoid the tunnel coalescence. But it is very easily said than done. So normally it is better to do a single bundle PCL and do a modified Lind method. That is Danish method,
Danish.
rather than doing a Laprade procedure, because they, in long term, they actually fare the same way. So please do not get into trouble of tunnel coalescence trying to replicate anatomy, which probably one is never able to do, to be honest.
Yeah, totally agree. So I think let's go on with the last talk and then we'll have more time for discussion after that. So thanks, Chinmay, joining in from London. I know it's a Saturday afternoon for you, but I really appreciate you taking out time. And we are going to hear from Chinmay, techniques and outcomes, especially in elite athletes having PCL injuries. So over to Chinmay, and we look forward to your talk.
Thanks very much. Just checking you can hear me okay?
Yeah.
Lovely. Thanks very much. Great pleasure to be here, so Parag. It's a real privilege to be asked. So you've heard an amazing talks regarding both double bundle, single bundle, and anatomy. And I'll be coming back to some of those in the context of elite athletes, the stresses they put in that context. And really what we're going to focus on is the isolated versus multi-ligament injuries, when to manage elite athletes conservatively, because I think there's definitely a role for that. Technical themes like graft choice, single versus double bundled, and the difference between sports and positions, which I already very, very briefly alluded to in that question, and then the outcomes. I'll just point you towards another anatomy paper that we published actually before the one that was quoted in 2006. It's really by Andrew Amos. Obviously, I'm part of Andrew Amos's group. Amazing anatomical diagrams regarding the femoral insertion. I actually spent 3 years of my life doing a PhD on the meniscofemoral ligaments 25 years ago. So we published a few papers on that. So it's really important to understand those anatomical and biomechanical points that have already been made. And particularly this AL bundle is very important. A contact mechanism of injury, Aussie rules football, but footballers have these non-contact, and that's obviously important in the context of when to reconstruct, which techniques to use for reconstruction. There's no doubt that PCL results in posterior tibia, increases the patellofemoral contact pressures. When that tibia also rotates the patella, translation, you will have an effect on patellofemoral biomechanics. All PCLs need to be reconstructed? No, but it's something that's worth considering when you are deciding to operate or not. And obviously the quadriceps brings the tibia forward, the hamstrings brings the tibia back, so you don't want to do isolated hamstring exercises in your post-op regime for the first 3 months, and you really want to strengthen your quads. There is definitely a role for non-operative management, and this paper by Faris Haddad's group back in 2017 showed that actually isolated PCLs, grade 1, 2, managed with a jack brace, with the brace placed on the knee for 3 months when they're asleep, and probably for 2 months whilst they're rehabilitating, gives you a good return to sport rate at a fairly short period of time between 10 and 16 weeks. So it's not that all PCL injuries need to be, and both these injuries are a combination that patient conservatively you have to reconstruct is lower in the elite through much greater stresses. And when you think about all of that, you've got to think, what's my graft choice? What are we going to do, single or double bundle, and what fixation techniques are we going to use? This is actually a Paralympian, and what he had was a MCL, ACL, PCL. Notice no pivot shift and anteromedial instability as well. So in that situation, just coming back to the point that was made, I'm planning a single bundle because I'm going to have to reconstruct that MCL, which had already been repaired in the past and that had failed. So graft. It's best to summarize that there is no one graft that's superior to other in clinical outcome measures at the moment. However, the quads tendon with a measures at the moment. However, the quads tendon with a bone block does seem to have a good fixation. Basically, for a graft, you need at least 10 millimeters for your AL bundle. I think that's really important. You need a big, strong graft. The PCL is the strongest ligament in the knee, and you need to have a very strong graft. It's debatable as to whether you want bone healing or soft tissue to bone healing. I'll come back to all of that in a minute. You've got to think about whether, as I said, the patient is sprinting, in which case don't take the hamstring tendon. If they're pushing hard, in which case probably don't take the patella tendon, and consider allograft. I think allograft in particular with these injuries over 35s, because they're long and they are thick, important to ask for, otherwise they give you anything. We've already talked, gives you a more stable knee with less posterior draw and probably slightly better feeling knee. However, if you then go to IGNA scores, there's no difference. So point was made, you've got to be familiar with what you're doing, is because someone else, even the best in the world, is telling you to do it. You've got to be familiar and you've got to do it safely. So I think that's really important. But given all of that, if I have an elite and it's an isolated PCL or a PCL posterolateral corner, I will do a double bundle. If I have an elite and it's a PCL MCL, posterolateral corner or ACL, I will do a single bundle. I am terrified of fracturing condyles with 3, 4, 5 tunnels in the same condyle, and so I will do a single bundle for an MCL injury. Inlays I don't have any experience with, but I think certainly if you're thinking about tunnel problems, you're worried about fixed flexion contracture, you want to do a posterior release and you're doing a revision, it's a technique that can be used. What about remnant preservation? Someone already mentioned this. I think it's really important, and here you can see I've used a passport cannula and a citron stick for the PM portal. Now, can you take all of the PCL? I try and preserve the meniscofemoral ligaments because I'm obsessed about them. How much of this do you take? Well, I think the answer is as much as you need to see and be able to pass the graft. And I think this really helps as well, is the graft passer. So we try and preserve as much PCL remnant as possible, and we try and preserve the meniscofemoral ligaments if at all possible, mainly for lateral meniscus biomechanics. What about isolated PCL outcomes? Generally very good. And you've got an 80 to 90% return to play rate, both for patella tendon and hamstrings. And female versus male, actually the females have slightly better laxity correction, probably because they have a higher tibial slope, so that actually helps you resist posterior draw. Multiligaments, slightly less return to play rates, only 1/3 regained the exact pre-injury level of Tegner score. I think obviously a lot of this depends on who it is, who's doing the surgery, how well it's done. But I think when you have an elite athlete and they've got this kind of injury, you have to say your knee may never be the same again. I think you have to be honest about that and manage their expectations. What about elite different sports? Andy Williams' group reported on football, rugby, and they suggested that there's a good set of results with PCL-based injuries requiring a longer time to return to play versus ACL-based injuries, and bicruciate injuries, again, requiring longer time and slightly less return to play rate. So definitely the ACL, PCL, and ACL, PCL, LCL group have a poorer prognosis, again confirmed by this NFL study, than the PCL, LCL, or PCL posterolateral corner group. What about women? Well, women, as I said, they have slightly less, better restoration of their posterior draw. But I think it's a talk I gave at the ski conference, which is that women have a greater phobia of movement and a greater fear of return to play. So they need to be managed very differently in their post-op period. They have greater femoral anteversion, greater valgus, poor landing mechanics because of that. So I think the rehab in women does need to be very different. And coming on to rehab, the elite athletes will be tested to a very high level by their trainers, their physios, even to some extent their agents. But I do some of these tests in the clinic myself just to understand what their landing mechanics are like, because you want to progress on criteria-based testing, not just on time-based testing. So where can we go in terms of future research? I think it's pretty obvious. Graft choice, double versus single bundled, looking at long-term sequelae, bracing regimes. We don't really know what we should be doing with bracing, how long for, how long should they be restricted in their range of movement. So that's all worth looking at, and the return to play testing and testing batteries specific to the PCL. So I think what you've learned in the last 4 talks is that there are many different ways to play the same shot by different people, but ultimately you need to have a great result, but you need to get the basics right. And the basics in PCL are a strong, healthy graft or grafts, optimal tunnel position, good graft tension with early mobilization, but protecting that posterior tibial sag, certainly for the first 3 months, and infection-free healing. And then, I mean, Dinshaw did an amazing job with this man. I couldn't believe his results. So congratulations. I'm sure Dinshaw's not on the call, but that was incredible. So, take-home messages. Think about the patient in front of you. Think about the sport. Think about their position and your tunnel coalition, graft selection dependent on the injury that the patient suffers. And just a plug for our Imperial Sports Knee meeting, it may well be online. Obviously you can better get back on your tax. Come to London in January. We'd be delighted to have you. Thank you very much.
11
As I said, lower threshold for reconstruction, because you can't really experiment with these guys. So but going back to you do not want to permanently damage them with fractures or really poor grafts. So I think I always compromise that feeling of, oh, have I got the biomechanically the best construct with what's safe and what's effective.
Okay.
Yeah, Dr. Sachin.
Yes.
Hello. Yeah. Dr. Sachin, very good talk. What is your threshold for isolated PCL reconstruction in elite group? Whether invariably go reconstruction in elite group, whether invariably go for a conservative treatment to decide what to do? How you approach in isolated PCL tear in a elite athlete?
So you're asking
Yes,
me, Chinmay, yeah. Sorry, yeah.
Yeah,
Stress views are very important, I think. The stress views will give you a really good idea. And then if you've got grade 3, you've got to reconstruct. If it's grade 2, you can have a conversation, and that may depend. So some sportsmen will say, oh, look, I've got to get through to the end of the season, otherwise my contract won't get renewed. So then you won't reconstruct. So all of those other factors come into it as well. But I think the stress views are important.
So in those cases, do you prefer in any elite grafts that are being used
that's the
nowadays?
same question I had in my mind,
Yeah,
Chinmay.
yeah. Off doing synthetic grafts. I had good results, but at the 10-15 year mark, if you've got no remnant, they will fail, and I've seen that in my because it's polyester. So I don't use synthetic for articular ACLs. I used to for MCL, but really I've gone in this country.
Yeah,
Can I
Milind?
ask a question? Yeah. Chinmay,
Sure.
this for you. The most controversial part today about rehab of PCL reconstruction is bracing. The kind of bracing, the time of bracing. Rob Laprade goes to the extent saying that absolutely against bracing. So,
Yeah.
as far as PCLs are concerned, what is the
So I will use a brace at night for up to 6 months because I think that's an easy thing to do. Even then, the patients, affects their sex life. They don't like it. So, that's why my recommendation is to use it at night to 6 months. I think in terms of compliance, you won't get people wearing a brace for more than probably 3 months if you're lucky. So I think you've got to be practical. I would generally use a PCL brace for 2 months at least, and ideally three. The other thing is, if you're going to use a brace for that time, do you anticoagulate? There's a lot of debate about that. So I at least put them on aspirin. So I think bracing, it was in my final slide, is that there needs to be a lot more work. In that immediate 24-hour, probably first week post-op period, I braced them in extension with one of those. It's actually a splint with a posterior force on the tibia.
Yeah. Good. So I think I have. So this is a 42 male who presented to me with a kind of a twisting injury while playing football. It was right knee. Now difficulty in descending the steps. So this was his clinical evaluation that the tibia was sagging behind. This was about 6 to 7 months. He came to me. Uh, so what are the clinical tests you do, Ranjit, for your patients when you see them?
Hello. The clinical
So
test most
which
important.
all
Hello.
clinical tests do you perform?
Yeah, the most
Yes.
important. Hello. Yeah, the
Yeah, please
most
go ahead.
important.
We can hear you well.
Yeah, test is posterior sag test. If your tibia is sagging behind as compared to the first, and then the posterior draw test, how much of the posterior translation is the extension rotation test. So
As you can see here, this was
yes,
at
yes.
very surprising at 7 months, just a history of positive, and these are the patients who actually scare me.
Yeah, I mean, he's obviously symptomatic 7 months post with a really massive posterior sag. So I think you've got to think of for him surgery. Got to rule out other injuries as well because it's probably just a single bundled, big thick PCL graft in him.
So even if
The posterior stress X-ray, and if on that, depending on whether it's a complete or a combined injury, I base my decision more of posterior drawer test.
absolutely, Dr.
a cross table lateral? I would always get a Rosenberg view done to see the medial compartment. Hip to ankle scanogram with the patella in the neutral position to understand the mechanical axis. If the patient is above 40 years of age, which this patient is, and probably a skyline view as well, because that is going to tell me about a chronic PCL deficiency and whether there is some.
Okay, we also do in addition what Dr. Bartlett view or the stress view, which is on kneeling down on a stool. We find is better. Actually, does help us to decide what particular stress. You can see that the subluxation is not that much, and therefore I think the stress.
Parag sir, just one comment.
Yeah,
In
sure.
such a clinical probably change. So in such a obviously presenting PCL deficiency, stress X-rays of course have role, but not probably in this patient. So here
Right.
I would be more reliant upon the collaterals and the PLC because I would like to know what is the status of the dial test in 30 degrees and 90 degrees of flexion. And with grade 3 PCL, that would probably change or that would formulate my treatment plan.
Absolutely. So, a quick question to Chinmay at this point of time. How much importance do you give to slope? Of course, here the slope was, quite normal or slightly neutral. But, do you do a sagittal scanogram to check for slopes. We are talking a lot about the posterior tibial slope
Yeah.
as one of the factors ACL reconstruction surgeries. So what's your take on the slope, Chinmay?
Yeah, you can tell even on your lateral here, that will give you a good idea. But and more concerned about other injuries that have been missed. But no, I wouldn't do a sagittal scamogram on a primary PCL. But for a
Yeah,
revision,
right. Any other take on the slope, Dr. Milind?
For a primary, I would never do a monopedal stance scanogram to see for the prudently and after a lot of thought, even in revision scenarios. That's absolutely a personal opinion. But for
Right.
primary, never.
Right. So I think, of course, we did the stress view, which you can see here, and then we did the MRI, of course, which shows the PCL tear. We subjected this patient because I thought, he was doing active quadriceps, so we thought of doing a double bundle. His floppy ACL was positive as seen here, and then we went ahead to do a double bundle technique. So what sizes do you prefer, Dr. Deepak? What is the minimum you want for your anterolateral bundle or the posteromedial bundle, and or how do you decide the size,
So
Dr. Deepak?
minimum for AL has to be 8, and for the PM usually 6 or 7.
Okay, so 8 is minimum, and you can go up to 9 or 10, and 6 or
Yeah, yeah.
7 for. Okay, Chinmay, if you're doing a single bundle, what is the minimum size of thickness of your graft you would like to have?
10
10.
minimum.
So,
Yeah.
in case you don't get it, then you kind of use a internal brace and get it up to 10.
Yeah, yes is the answer. Or we augment. It depends on whether you use an allograft, because allograft you'll always get it. I think if you're
Yeah.
doing a quadruple semi-T, you generally get a 10. You could augment with a contralateral semi-T if you wanted to. So I try and get a 10.
For the AL and 7 for the PM, and this is his intro picture. I think we need to discuss a little more about the post-op rehab. And for me, I generally standardize these patients to keep them for non-weight bearing for 3 weeks, even if they are isolated. Of course, if they have an associated meniscus, then they do get non-weight bearing. 50% partial bearing at 3 weeks. And one of the important things which is not mentioned in the slide is what you mentioned, Chinmay, is the posterior support, the posterior tibial splint, which kind of pushes the tibia in the front. And I particularly found that useful, and we've done kind of a modification of that, and we use that in PCL cases all the time. Any difference in the post-op rehab, Dr. Milind or Dr. Chinmay?
So
I start my.
Yeah, Milind
Chinmay, go
first,
ahead.
and then we'll go
After
to.
you.
Yeah.
please go ahead.
Okay. So my PCL patients are partial weight bearing right from the word go, as these are isolated PCLs. When they tolerate weight bearing, I put them on a same modification of the long knee brace where we add a pad which pushes the tibia in front. And even if they have a meniscus tear, I allow them toe touch weight bearing, but the condition is the knee should be in full extension, no flexion at the knee at all, which puts centrifugal forces and helps meniscus to heal, as well as to tolerance. They can start weight bearing right away on day 3 or day 4. But it is always a partial weight bearing. My patients, they get converted into a hinged kind of a dynamic brace at the end of 4 weeks. 4 weeks onwards, they almost start with full weight bearing, which is contrary. But then the literature has support, and 4 weeks onwards, one can start with full weight bearing mobilization, but not active quadriceps, active hamstrings.
Yeah. Anything different, Dr. Deepak? You wanted to say something?
Yeah. Actually, we start the knee bending day 1, but it is usually for the first 2 or 3 weeks prone knee bending to negate the effect of the hamstrings. Rest is more or less the same 2 weeks partial weight bearing, and then we, as per the comfort of the patient, and again depending whether there is any associated injury that we are dealing, whether the meniscus. So weight bearing depends on that, but yes, knee flexion day 1, but in prone position.
So Chinmay, this was the same patient, and this sometimes the anterior step off which we get on day one. Now this is an X-ray nearly at 5 to 6 months. That step off is not seen, and actually there is, if you see the posterior slightly, it's in the posterior subluxation, but clinically is very stable. So does this worry you, Chinmay? This kind of X-ray, or if it's clinically stable, but the tibia is slightly subluxed posteriorly. What are your thoughts?
And honestly, I mean, I think you improved the tibia by 2 grades. I think, if I'm being honest, I will have a little bit of a sag, not a sag, but lack of anterior step off in quite a few patients. That's acceptable as long as they're not symptomatic with it. So I think, if you look at things objectively, a lot of surgeons will say that
Yeah.
they won't get a complete restoration of the anterior step off in the long term.
Exactly. So that's always my concern. So I'm glad you also the same thing. The next 2 to 3 minutes.
One quick comment.
Sure.
So I forgot. So please pardon me for not
No,
mentioning
no,
that
no,
word
no.
of
Come
thanks.
on.
I take this opportunity to thank you to invite me for this wonderful webinar. Thank you very much.
No, it's a pleasure. And I think
Perhaps one question, like for the newcomers, is there any role of using a C-arm? Though it is very basic question, like a role of using a C-arm. Any role of using a C-arm? Though it is very basic question, like a role of using a C-arm for especially the tibial tunnel. Like, what
yeah.
is the expert says on this?
I'll take that. So
What is your take? Yeah.
the answer is I do sometimes use it. You know what I use? I actually use the Lars jig. I think the Lars jig is the best jig for PCLs, but I use it in a non-Lars function. So I drill my tunnel with the Lars jig. Sometimes I use the C-arm to make sure my tunnel's in the right place, but I think it's very reasonable. You want to be safe, and I don't think you should be ashamed of using a C-arm if you need to.
Okay, so I think with that we will close. It's about an hour and a half, and it's a Saturday evening, so time to hit the bar. I want to thank all the panelists for their participation. Thank you, Deepak sir. Thank you, Dr. Ranjit.
Thank you so much.
Thank you, Dr. Sachin, Dr. Milind,
Yes,
and
sir.
Dr. Chinmay. Really appreciate you taking time out on a Saturday afternoon. And I want to thank OrthoTV for having displayed this. And Dr. Ashok, you can give us the statistics, how many have joined till now. So really thank you, Dr. Ashok, for running
Thank
this on
you.
the Ortho TV platform, which is a very popular platform, not only in India, but all across the world. Over to Dr. Ashok for concluding this webinar and concluding statements from him.
Before that, I
Thank you
really
very much.
thanks.
I think, yeah, go ahead, Sachin. Go ahead.
Before that, I really thanks Parag sir and OrthoTV. Really, by sharing the knowledge, always increase. So nice insights on the PCL. Thank you, everybody. Yeah, so continue.
Thank you.
Thank you very much, sir. I think this arthroscopy webinars are turning out to be a great crowd puller. A lot of youngsters are logging in and rewatching all the content again and again. So it's a great effort. I'd like to thank all the faculty here who has spared their time on Saturday evening and being with us. So thank you very, very much. And it was an excellent session. All the talks were so exhaustive and the Q&A session was really interesting.